Very good morning to all and Happy New Year. I am the opening batsman for this year, so let me start without wasting any time. So the topic given to me is frailty in pediatric liver diseases, and this would be the outline, that would be the definitions, the problem statement, the mechanism behind it, how to assess and diagnose, and how to intervene if possible. So let's start with the definition. We still do not know what definition ideal term that we have to use, whether you have to use frailty or you have to use sarcopenia, or you want to call the patient cachexic, or you want to call him malnourished, whatever you want. So let's start with frailty. Frailty was a term that was used in geriatrics first. It is a global measure that includes cognitive, social, emotional aspect along with physical frailty. And you have to look through the entire spectrum. You have to look through the daily living activities, their physical capacity, their endurance, their aerobic capacity, including the common tests that you use. And ideally, it also includes sarcopenia in this definition, that is the muscle mass. And it is the most dominant subcomponent of the entire frailty construct. And as you know, that it is the most objectively defined parameters that we use. Now, sarcopenia, as in frailty, was first defined in geriatrics when they used three terminologies. One is the muscle strength, second is the quantity or the quality, and third is the performance. So quantity and quality is the most important or most objectively defined measure, that is the mass, and strength and performance are the other two measures. So multiple societies have tried to define it. If you look at the societies, the definitions, they start with muscle strength, not the muscle mass per se. So that means they start with muscle strength and then go on to quantify their muscle mass, and then subsequently they look at the physical performance to define sarcopenia. And all the other definitions have also started with muscle strength. So this means that your strength and performance, or what your muscle is capable to do, is much more important than the quantity or the quality, that is the mass. So sarcopenia, subjectively or objectively, if you want to define, the guidelines have said, yet to you define frailty predominantly based on their strength and performance, and you define sarcopenia practically as the loss of muscle mass. So what term to use? You can use whatever term you want. You can call it frailty, you can call a patient frail or sarcopenic. Try and define all the components individually, because all these matter. Not just, if you can tell your patient that your muscle mass is less, does not matter if he is able to perform functionally well. You ideally assess both in every patient, both the muscle function as well as the muscle mass. Now what is the problem statement? We all know that it's very common. The prevalence of frailty varies even up to 3/4 of the patient that you try and evaluate. In children, there are not many studies on frailty, but one study had defined a 25% median of frailty prevalence, and sarcopenia roughly varies around the same prevalence. We all know that these frailty and sarcopenia, they worsen with disease severity and may also have delayed recovery and even worsen in the initial few months and years of post-transplant. This is the compilation of the pediatric studies on frailty, sarcopenia, in which the prevalence has varied from around 23% to 56%. And majority are retrospective, some are prospective cohort studies also. Frailty, I could only find 3 studies. Last two have been done in liver disease patients. This was a study that had quoted a 25% prevalence, and multiple other studies have predominantly been done in sarcopenia only. So we all know that sarcopenia is associated with pre-transplant and post-transplant mortality also. It is associated with increased hospitalization, healthcare costs, readmissions, length of stay. Also, frailty has been, other patient metrics, frailty especially has been associated with increased risk of falls, depression, poor quality of life and disabilities. And even in post-transplant, it may tell you that if the patient is sarcopenic or frail in the initial period, it may have poorer recovery in the post-transplant period. Now if we go to the pathophysiology, not much is known, but it is a crosstalk between liver and the muscle. So first, let's start with the basics. So when we know that this is a normal metabolism in any adult patient, you take a food, you start fasting. So these are 1, 2, 3, 4 phases of fasting that a patient undergoes. So once you start fasting, your first period, the glucose source is your exogenous food that you have taken. then subsequently the glycogen starts breaking down, and the glycogen content usually gets exhausted by the end of first day. Simultaneously, as the glycogen content goes down, that the glycogenolysis is happening, your gluconeogenesis. So gluconeogenesis is nothing but that the body is trying to produce glucose from non-glucose sources like fat, muscle and everything. So that gluconeogenesis proportion starts increasing. So once you go into the late phases of fasting that are non-physiological per se, the second, third and the fourth phase that go beyond the first 24 to 36 hours, what is happening? Your fatty acids are being broken down. These fatty acids subsequently lead to increased ketone formation. So here the body wants to produce glucose, but it does not have glycogen inside. So what it will try to break down your fats first, and then it will try to break down your proteins later. So this is a small diagram that I have made. So if you have fasting blood sugar, your glycogenolysis starts happening. It tries to compensate for the glucose production. It produces and provides glucose for the body system. But if you have protected fasting, your gluconeogenesis start acting, and you have muscle and fat catabolism to lead to increased fatty acids and ketone bodies to produce glucose. So what happens in cirrhotic patients is this metabolism gets altered. So they are in a state of accelerated starvation. So what they have said that if a cirrhotic patient can exhaust all their resources of glycogen within 8 to 10 hours compared to an adult patient who will require at least 24 to 36 hours to exhaust the same resources. So if you see compared to controls, you can see the glycogen content of the liver goes down. There is increased gluconeogenesis. Cirrhotics are trying to break down their muscle and protein simultaneously. Studies have shown, these are older studies, but they have shown how the glycogen content of the cirrhotic liver is pretty less compared to the control patients. As also there is increased risk of glycogenolysis and increased gluconeogenic content of the liver. So this was a wonderful study that was published in 1997. So this is the fasting in a patient of cirrhosis, and this is a fasting in a patient of control. So if you see the proportion of fat that is being used by a cirrhotic patient and the protein is comparatively very high compared to a control patient. So this is the fat which is broken down by cirrhotic patient, and this is the proportion of fat and protein that is being broken down by a normal patient. So once you give a late night snack, so that this was a paper when late night snack concept came up. Once you give a late night snack, look at this, the proportion of fat being broken down and the proportion of proteins being broken down by the liver, by the body, has come down if you supplement just one late night snack after they have taken a dinner. That is about 50 gram of complex carbohydrate that you can give. So the entire concept of frailty and sarcopenia revolves around these concepts. You start with hyperammonemia, systemic inflammation, you have nutritional deficiency and substrate depletion, you have endocrine abnormalities and specific myokines related abnormalities like increased myostatin and activated ubiquitin proteasome pathway. I'll go one by one. So most important concept of liver and frailty is hyperammonemia. What is ammonia? Ammonia is nothing but a breakdown product of purine metabolism, amino acid metabolism. What happens in normal physiology? Your brain, skeletal muscle and lungs. So skeletal muscle is the most important nitrogen or ammonia metabolizer. So what they usually do, these ammonia which is being produced by different mechanisms gets converted into glutamine by glutamine synthetase. This glutamine goes into the circulation, and liver is the part where ammonia metabolism takes place, and ammonia is converted to urea cycle. So this is where urea cycle comes up. But what happens is, if you have liver which is not working, what will happen? This ammonia will not get converted to urea. So your blood ammonia goes up. Now skeletal muscle has to work very, very, very hard to metabolize this extra ammonia that the liver is not able to metabolize. So what happens is, this ammonia gets converted into glutamine, and this glutamine cycle continues. So what happens is, when you have hyperammonemia, your brain and muscle are overworking, it is increased glutamine synthesis, glutamine goes again into the blood, and this cycle continues. Then glutamine gets broken down by the enterocytes and the kidney to ammonia, and this vicious cycle continues. So this is the reason why they say that if you are to save your cirrhotic patient, you should build up their muscles, because muscles can metabolize the extra ammonia that the liver is not able to metabolize. Now what happens is, when you have excess ammonia, this ammonia goes into the muscle, and because the muscle has to produce glutamine to metabolize this ammonia, it takes up these branch chain amino acids. So these branch chain amino acids along with alpha ketoglutarate have to produce glutamate. Then this glutamate will utilize this ammonia to bring it down by forming glutamate. So this is the reason that the branch chain amino acids deficiency takes place in your cirrhotic patients, and therefore you have to supplement these in order to bring down your ammonia levels. Now multiple other factors also take place for causing frailty. So frailty means that there is an imbalance between muscle protein synthesis and muscle protein breakdown. How does muscle protein synthesis take place? You give amino acids, glucose, insulin like growth factors, they go inside, activate this IGF-1, phosphoinositide 3 kinase pathway, then the AKT, and this mTOR is the common pathway in which how they lead to this ribosomal 6K and 4-EBP1, which leads to muscle protein synthesis. On the other hand, the muscle breakdown takes place through 3 pathways. One is the autophagy pathway, second is the ubiquitin proteasome pathway, and third is the calcium dependent calpain pathway. So when this inflammation happens, it activates the NF-kappa B pathway, which induces myostatin. Second pathway is this NF-kappa B activates the autophagy, this MURF1 and MAF-BX1, which lead to muscle breakdown. In sarcopenia, what happens is you have increased inflammation. I will not go into much details there, but systemic inflammation because of increased cytokines like TNF1, TNF-alpha, IL-1, IL-16. They increase this inflammation, go down this pathway. Simultaneously, if you have growth hormone resistance, growth hormone deficiency, as well as testosterone deficiency, these lead to impaired muscle synthesis, and increased inflammation leads to increased muscle protein breakdown. Ammonia, what it does is, it enters through this RSCG, RHBG pathway, causes mitochondrial dysfunction because of, I have already explained that alpha ketoglutarate goes down. Alpha ketoglutarate is a metabolite for TCA cycle. So if this goes down, your TCA cycle does not work, your Krebs cycle, the Krebs cycle does not work, it does not lead to good electron transport chain, ATP synthesis goes down, simultaneously increases reactive oxygen species, causes increased muscle turnover. Second, simultaneously what it does is, it creates what is called as integrated stress response because of amino acid deficiencies, activates this general control non-depressed type 2 receptor, which inhibits this mTOR pathway. mTOR is for synthesis, it goes down. Simultaneously, it also activates myostatin and simultaneously lead to sarcopenia. Other factors, I have already explained that pro-inflammatory cytokines, some drugs, even physical activity can also lead to sarcopenia. So, the most important thing is, how do you assess a patient whether he is sarcopenic or frail? So, I have already mentioned that mass along with strength and performance should be simultaneously reduced, simultaneously evaluated if you want to define a patient as frail or sarcopenic. So there are multiple measures that have been used. Global frailty, some indices used to evaluate the entire spectrum of frailty. These are the indices. Some use only the physical frailty, that is the more commonly used, liver frailty index, 6-minute walk test, gait speed, and sarcopenia has been defined objectively using imaging. That includes CT, DEXA, ultrasound and body composition math. And some parameters like Freud frailty and hand grip simultaneously converge between these three. So let's start with anthropometry for sarcopenia. Safe, inexpensive, you can seriously use it. CT, though there is radiation exposure, it is the most validated measure for defining sarcopenia. You can use ultrasound to define muscle thickness, but it is inexpensive, but there is significant interoperator variability. You may use the DEXA scan, but it is reproducible. There is minimal radiation. I'll explain this later also. And also MRI, not very validated, but may come up soon. What sarcopenia is, defined by CT or MRI, what they use is, they use the skeletal muscle index. They try and calculate the entire area of all the muscles, including the psoas muscle, rectus abdominis, and rectus spinae, all the 7-8 muscles that surrounding, usually at the L3 level. Some studies have tried to define only on the basis of psoas area, but it is not very well dated, and a couple of studies have shown that it does not actually correlate with the increased mortality risk that these patients are having. And the important thing is you need a dedicated software for using these parameters. Muscle thickness has been defined in couple of studies along with the muscle area. So this was a study that was published by Prabhsan. It is unpublished till date, but based on muscle area and muscle thickness that she did based on ultrasonic parameters, she found about 30 to 80% incidence of sarcopenia in our patients. Also, we could correlate that pre-LT and post-LT there was significant increased risk of morbidity and mortality in our patients. And also, we could define that the native liver survival was poorer in patients who were sarcopenic. DEXA scan coming up. Nowadays, whole body DEXA scan, it tries to calculate the fat mass, the appendicular lean mass. You can content the bone mineral content, and some cutoffs have been given for this appendicular lean mass in these studies. Some people are very scared of using DEXA scan. They say that there is increased risk of radiation. I'll explain this later also. And the second important thing is the body composition analysis. Some of the parameters like whole body phase angle, skeletal muscle index, skeletal muscle mass area, and visceral fat area have been evaluated as proposed parameters for defining sarcopenia. So if you are worried about using DEXA scan, just look at this slide. Your DEXA scan, your one chest X-ray is equal to more than 10 DEXA scans that you do. Look at the kind of radiation that one DEXA scan provides. So DEXA, if you do it for bone mineral density, is just 1 microsieverts. Whole body DEXA is just 5 microsieverts, and your one chest X-ray is 100 microsieverts. So even if you do, say, 6 monthly or yearly DEXA, there is not much radiation. So don't worry about using whole body DEXA scan just for the scare of giving radiation to the patient. These are the frailty indices that I was mentioning. The Fried Frailty Index is the only measure that has been used in children. Couple of studies that I have shown. And the Liver Frailty Index is very popular in the adult patients. So this is the parameters that the Fried Frailty Index modified in children that we are using based on grip strength, gait speed, body composition by tricep skin fold thickness, and exhaustion and diminished physical activity, including the validated questionnaires. So in children, majority of the studies have used CT scans, couple of studies have used DEXA scan, and the frailty has only been defined based on Fried Frailty criteria. So what to use? If the patient is, we will not prefer using CT or MRI unless the patient is undergoing a CT and MRI for an unrelated reason or for research purposes. For routine purpose, I believe we can use ultrasound body composition DEXA scan because they are non-invasive, though there are no pediatric data available, there are no local or reference data available from local population, but if you can use it baseline and follow up of the patient using any single criteria that I mentioned, you can always use them. Or what you can do in your routine practice, you can combine these two factors. Say you use a hand grip strength and you follow it for the patient. Or you use muscle mass on BIA, which is typically there is no radiation. And you follow those patients longitudinally. Whatever you feel like, whatever practical you think, you can use these. But you have to combine mass plus strength or function assessment. So how do you intervene? You screen, you treat, and you manage the complications. The most important thing is you use the primordial prevention, that you avoid the occurrence of sarcopenia or frailty. So it's a teamwork. No one person can do it. You need an entire clinical nutritionist, you need a physiotherapist, you need counselor, and you have to deal with the primary physician. So what you can do? You can treat the hyperammonemia. We all know how to do it. You can try and manage systemic inflammation using treating infections, even microbiota rehabilitation had been tried in a couple of studies, not very well dated. You can use folistatin. A couple of studies have used folistatin along with testosterone use. Not very well dated, yes. So the red ones that I have highlighted are the ones that you can actually do in your routine clinical practice to help out these patients. And the most important things are going to be your improving the nutrition, decreasing the fasting periods, may or may not be with it, branch chain amino acid supplementation. And the most important thing that you can add in your patient is a late night snack. Now I'll focus more on exercise and nutrition first. So exercise, couple of studies have shown that exercise improves the frailty and sarcopenia. But there are multiple barriers to exercise. The most important barrier is that if we fail to tell a patient to exercise? How many of us sit in our OPD and tell our patient, along with writing a prescription, that you have to exercise? Not many of us. So there are multiple barriers that you have to assess, including the social, the healthcare professional. The most important barrier are us. We lack individual assessment, individual encouragement. There are some disease-related factors also, and along with mental health. So this was a study that is being done by Deepika in our protocol. We are in frail patients who have been defined by Frailty Index. We are giving them exercise regimen for 12 weeks, and we have devised a protocol, indigenous protocol for exercising. We have divided for aerobic and resistance exercise. These are photos from our own patients, how they have been asked to do the aerobic and resistance exercise in our protocol, and this protocol is still ongoing. So what you can do in your practice, just ask them to exercise. There are no, people have defined fixed norms, but I don't think that norms are helpful. Tell them to exercise, combine the aerobic resistance exercise after they have cleared the safety checklist, and this should be done under supervision because there is risk of falls, there is risk of fractures in patients, especially the adult cirrhotic patients. Nutrition, the second most important thing. Titrate their protein and energy intake. Ensure that they are fasting. So most important thing is when you are fasting your patients for repeated procedures. A patient who, don't tell them that you need to be overnight fasting unnecessarily if you are planning a procedure to do it in the late afternoon or the evening. So they have any guidelines, whatever the American Society of Anesthesiologists, what they have said that the maximum duration of fasting that you need is 8 hours. So don't give a blanket statement that you need to be overnight fasting. Titrate their fasting durations, especially with the time you're planning your procedure. So branch chain amino acid I've already mentioned. There is increased risk of deficiency in cirrhotic patients, and when you give branch chain amino acids, it helps your muscle bring down ammonia levels. So studies have been done, but there are still conflicting reports in literature regarding the use of branch chain amino acid. So I believe that branch chain amino acid may not be the requirement in every patient, but if you are not able to fulfill your protein requirements, then you may try and add branch chain amino acid and give a trial to these patients. So just to summarize, this is my last slide. If you have a cirrhotic patient, especially who is decompensated, there is very high risk of frailty and sarcopenia. You try and suspect your sarcopenia and frailty in all patients. Once you suspect, then only you will be able to assess and diagnose and then manage. Second step is to screen and diagnose. You choose. We do not need, everybody, all of us know how to look at a patient who is sarcopenic or frail or cachexia. The first test you do is eyeball test. You look at the patient and you see that he looks sarcopenic. Then you choose a method. So what you can choose? You can choose a DEXA scan. I still believe that DEXA and body composition analysis will have major role to play in near future because they are non-invasive. Or you can do plus anthropometry you always have to do in all patients, especially in the pediatric population. Along with that, you have to choose one measure for your strength or function. You can choose one of these measures. You choose, let's say you choose, I will only use hand grip strength. That's okay. You can follow that hand grip strength longitudinally. Or you can look at 6-minute walk test or the gait speed also. So you have to combine mass and strength function, but the most important thing is do repeated evaluations. Choose a simpler test, whatever you can do, and follow and use the test repeatedly to define sarcopenia. Third step is to manage. We all know how to treat and manage cirrhosis, but the most important thing is diet and nutrition and exercise. Please ensure that their fasting periods are decreased, but in a daily basis or when you are planning a procedure. And the late night stack is the most important nutritional intervention that you can do in these patients. Trust your nutritionist and utilize the Lehab services. This is the last slide. So Lehab services, what they do, they will, in the first assessment, they will do a body composition analysis along with the functional assessment. They will tell you how to do the exercises. They will ask you to do one session of exercise, and they will simultaneously provide nutritional assessment and counseling. So if you think that the cost for this one session is 1,000 rupees, and if you think this is wastage of money, just look at the amount of tests you spend, amount of money that you spend on routine testing. I got my test done today, fasting sample. This is the amount I spent today. So one session of Lehab in which they are spending so much of time and money. so much of effort, not money, including their body composition, functional assessment, counseling, exercising, is just going to cost you 1,000 rupees. And the patient can continue these exercises later. So this is important. So I believe, rather than short of a liver transplant, if you have to manage your patient of sarcopenia, your exercise and nutrition are the only measures that can help you out. So acknowledgements, I'll thank Professor and Deepika for providing me their slides, Dr. Jaya and the Department of Clinical Nutrition, and Mr. Rakesh. And just to clarify, I have not received any honorarium for promoting Lehab services. Thank you so much.
Thanks, Vikrant, and you bring a lot of energy for the new year, and wish everyone a happy new year. Couple of points going back to Lehab. At least all my patients who get discharged are officially registered with Lehab. So every patient, my suggestion is, who goes out, is discharged, should have a Lehab enrollment so that they know it. And also, it's the first effort of its kind in the world. Rather than rehabilitation, it is habilitation. And it really makes a difference. Now, just a few points. One is on exercise. I'm sure Preeti, Sukriti's student, will someday tell you about the benefits of exercise. Follistatin is one of the best hormones which inhibits myostatin. And she has done, I saw her data yesterday on exercise in animals. And after exercise, follistatin goes up by 7 to 8 times. It's unpublished, I can't tell you. And follistatin is also in the yellow of the egg. So these two things can increase muscle regeneration. Back to your pediatric population, I think we need to differentiate and the benefits of anthropometry. We used to have kwashiorkor or marasmus, and these things were very easily picked up. So I think anthropometry must be the cornerstone of physicians, clinicians, hepatologists. Bone age used to be quite an important simple X-ray. And in addition to the anthropometry, I think DEXA is the routine, and every single patient should have body composition and DEXA. Now, one more thing which I think we should all think about is the routine measurement of ammonia in the outpatient. And pre and post food ammonia levels go up. So if ammonia is high, and then we should see that ammonia reduction, branch chain amino acids, and this. We need many more studies, and I think everyone here would appreciate new thoughts. Thank you. And
I enjoyed your talk immensely. I have some clarification. Like these guys, those who get sarcopenia in the liver disorders, they also have problem about they are almost anorexic. Their ghrelin content, I found, is disturbed. So the ghrelin is one which creates appetite. It's one of the hormones which is done in the intestine. And so in that case, the late night snack, I don't know whether they will take or not. Is there a position for enteral nutrition management in these guys, that so that you could provide nutrition which is required there? My second clarification is this: that that all these pathways which you showed, that like follistatin, Dr. Sasarin has already suggested, many of them can be handled, like the free radicals can be handled by antioxidants. Both NF-kappa B could be handled, like neoglucogenesis could be.
Sir, people have tried multiple cocktails. They have tried to use hormones, growth hormones, testosterone. They have used follistatin. They have used antioxidants that you have mentioned, but nothing works. at the end of the day, even if you try and supplement whatever cocktail you want to give, your cirrhotic patients will not develop their muscles and these things will continue. And the second thing is late night stack, you prescribe them as a medication. You don't give them an option that it's an optional thing. You tell them that it is important. You tell them the significance of it. And it's just like they are taking one extra glass of complex drink that your nutritionist is suggesting. So I don't think an extra glass or two or in an entire day, especially in the late night just before they sleep, is going to, and they can easily take these things. I don't think that should be an issue.
Vikrant, very nice. Happy New Year to everyone.
Yes.
So this sounds, I know lifestyle optimization actually can do wonders, and we also publish on this. Okay. Coming to cirrhotic per se, and when we talk about decompensated cirrhotic, because sarcopenia should be actually labeled as a decompensated cirrhotic, I think the science need to move from there. That ascites, jaundice is only decompensation. Sarcopenia is a decompensation of cirrhotic. We should include that.
Yes.
So my question really is there any data on actual lean muscle mass being increased in sarcopenic with lifestyle optimization? You can get with that, nutrition can do wonders, you lower down the calories and all those things can actually benefit anyone.
Yes.
Right? Especially in obese and all, right? But can you increase lean muscle mass?
Sir, lean muscle mass, yes. There are studies, they have shown that lean muscle mass after they have defined with CT also and other parameters also that it can increase after exercise and muscle just to prevent their morbidity and mortality pre and post transplant. So it's not just we cannot avoid a transplant by doing it, but there is definite evidence that it increases.
No.
I'll just, Vinay, there was a thesis done by one of the students. The title was NEXT. NEXT means nutrition, exercise and testosterone compared to nutrition plus exercise, and there was in 6 months time significant increase in the lean muscle mass in sarcopenic patients, but it was presented but still not published. But we have Rajiv to next talk, and Dr. Rewadi has some comments, please.
Thank you for an excellent presentation. My question was related to, you mentioned in passing about testosterone therapy. What is the exact role of, because we know that it helps in improving muscle mass.
A couple of studies have been done on testosterone, including IM therapy and everything, but and they have been done on short duration only. I did show the reference, but and they have been done on 3 months, 6 months period, and they have shown that muscle mass increases. But on top of that, you have to use injectable drugs, IM therapy, and you cannot use them on long for these cirrhotic patients. And short-term therapies, whatever you want to give, any exogenous drug or medication is not going to help out these patients. You can build them up for going ahead with transplant. That is, if you have a short-term target of 3 months, 6 months, that you want to build up their muscle just before they go ahead with transplant. But these won't have the kind of cost-benefit ratio as compared to exercise and nutrition.